Hello, and welcome to our inaugural Grand Street Rounds. I'm your host, Dr. Carly McMillan, and I'm the CEO and founder of Brooklyn Minds. We're a comprehensive mental health center based in New York City. We specialize in treating patients as a team for whom more traditional psychiatric help, such as the heavy use of frequent hospitalizations and crisis ER visits, has often been counterproductive. Grand Rounds, for those who don't work in medicine, originated as part of residency training to share new information and enhance clinical reasoning skills. Grand Rounds help people keep up to date on bigger picture ideas that may be out of someone else's area of expertise. Grand Street, for those who haven't visited our Williamsburg flagship office, is our first permanent home, so the mashup was a natural fit. Today, we welcome our postdoctoral fellow, Dr. William Osei, who will be presenting on his dissertation subject, John Henryism, an exploration of intention to seek help, self-reliance, and depression in African-American men. Dr. Osei received his master's in developmental psychology from the University of Pennsylvania and Ph.D. in counseling psychology from the University of Akron. Dr. Osei has extensive clinical experience in multicultural counseling. He has advanced training in the mental health of marginalized groups and understands how race, culture, and class contribute to individuals' health. Dr. Osei started his career working with at-risk youth in inner-city Philadelphia and has continued to advocate for marginalized communities. Before we begin, just a reminder that the content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your mental health professional or other qualified health provider with any questions you may have regarding your condition. Following Dr. Osei's presentation, we'll have a question and answer time, and we encourage you to submit your questions and comments to us or in the chat. All right, welcome everyone. Thanks for being here. And Dr. Osei, the Zoom is yours.
Well, thank you very much. All right, so like Carleen mentioned, my dissertation, was on John Henryism. And today we're going to talk about the role of story and Black men's bodies and health. And I think this is a really critical kind of time to be thinking about these issues, especially in the wake of like the murder of George Floyd and the Black Lives Matter movement. I think when we think about Black Lives Mattering, we really have to think about a broad spectrum of issues. And for me, mental health and is really critical to really the health of not only Black people, but I think, the United States as a whole, right? I think a lot of the issues we're suffering from are psychological, and beginning with the healing of Black people will be one of the first steps along that journey. So today we're going to talk about the power of culture in affecting the health. So we're going to discuss the goal of this kind of Grand Rounds. We're going to have a brief bio. We're going to talk about the state of Black men's health. I'm going to go over a little bit about my study, and I'm going to then finish out some breakdowns of some clinical takeaways. So if we were to leave with one goal today, my goal really is to have a better understanding of how Black culture can affect mental health of Black Americans. I think as clinicians and as people with Black people in our lives and us seeing a lot of the issues, especially on the news right now, it's really important to kind of think about ways in which we can give back on our daily basis or on our one-on-one interactions. And this is a very clinical presentation because I am a psychologist, but if anybody here is more of a layperson, they can really take away that what I'm trying to gain here today is how if we better understand the experience of other people, we can better help them. And I think right now when people are looking for ways to help, this is one kind of way or one model of understanding how culture can, better understanding of culture can be really effective to help. So the one thing I want you to think about is how does culture affect the experience of symptoms, the recognition of illness, how people seek help, and then how people seek treatment and how that treatment is experienced. So as mentioned before, I'm a postdoctoral fellow at Brooklyn Minds and adjunct faculty at Brooklyn College. I had my Ph.D. in counseling psychology, but I really started out in the developmental psychology world, studying human development at the University of Pennsylvania. And lastly, what's really going to kind of shine through tonight is my love of history. And so I want to talk about like my background as a history major in undergrad, but we'll really see how history plays a role, especially when we think about things like we might be hearing a lot about historical trauma. We'll talk about how things like that really impact the health of individuals. And so my three specialties, I would say, are the mental health of Black men and boys, multicultural counseling, and multicultural and organizational development. And to kind of understand where I'm coming from, I like was mentioned by Dr. McMillan is I really began as a direct treatment worker. My dad always used to be in hospital administration. So I grew up around a lot of residential treatment facilities, partial hospital programs. And so one of my first jobs was actually working as a direct treatment worker, working with boys who had been removed out of their homes in inner city Philadelphia and really put into these dorming houses in the suburbs, and really seeing how through just basic relational skills, meeting with people on one-on-one, these boys were really able to improve drastically, develop skills, advance in education. But the issue was that I would notice is that whenever the boys returned home, all the behavioral problems, kind of reemerged. And for me to kind of really fall in love, and that job is still one of my best jobs I've ever had. I'm still trying to recreate that experience of that summer. But that really led me to really be hungry about research. And so I joined several research teams looking at how behavior and environment really affect African-American men. And then that led me to, of course, my clinical work, really understanding, like, how do Black men even come to seek help? Like, maybe the question we're asking is not, why are they not here, but what are we doing to prevent them from even knowing that this is a necessary thing? And we'll talk today a lot about how to kind of, we know it's time to go get help for a mental health illness, which to a lot of people might seem like an obvious question, but we'll talk today about some ways in which that's a little bit more difficult. So we're going to start off with a story, a legend. And the story of John Henry is a really interesting story. It's about a man, really big, really broad-chested, and he was born into slavery. And he was born probably, when they look at the historical legends around this man, he was probably born in the 1820s to 1840s, and he was a freed slave. And one of his first things he did when he gained his freedom was he wanted to become a pile driver and a hammerman on the Chesapeake, Ohio Railroad. So his job was to drive these spikes in the railroads thousands of times a day. So you can imagine that kind of back-breaking effort and labor. And he was known as the fastest pile driver. And so, like, everybody talked about his skills. He was renowned for his skills, and he was loved for his skills. And then one day, the company he worked for, and this is the time of the Industrial Revolution, they brought in a steam-driven pile driver. And so everybody was like, oh, the steam drive is the way of the future. We don't need pile drivers anymore. And so John Henry challenges the pile driver because everybody's like, you know what, John Henry can do it. I've seen him do it faster. And the story goes that they raced and they had to break their way through a mountain. So when they came to a mountain, they used dynamite, they blew it up, and they kept working even through like all this kind of chaos. The end of the story is John Henry beats out the pile driver by a nose. And the part that's always stuck with me, I first heard this story when I was probably 6 or 7 watching, public television. And the part that always got to me was at the end, John Henry dies of a heart attack. And it was always kind of spun. There's even a Disney movie made about this. It's a short story movie that didn't really get a lot of popularity, but at the end of it, it's supposed to be this like tragic, romantic notion of this guy who like reaches the top of the hill, succeeds at all costs, and at the end of it, drops dead. And it's like it just always rubbed me the wrong way. And so when I became a psychologist and I started really thinking about like, I want to study something of African-American men. What can I study? And then this story popped up. I recognized the name John Henry, and I was like, what is this concept about? And so the concept is developed by James Sherman. He's a professor emeritus at Duke Sanford School of Health and Public Policy. And he, in the 1970s, was working in hospitals and finding that Black men were coming in prime of their lives and just dropping dead of hypertension, of heart disease, of high cholesterol, high blood pressure. And he just couldn't figure out what was going on. And so he went and he started interviewing these men. And he ran into this one guy, John Henry Martin, who was born a sharecropper. So, you know, his family's probably post-slavery, and he had this little plot of land. He was able to kind of not only free himself from the sharecropping system, so the sharecropping system is brutal. 90% of your income is going to somebody else, but he managed to do that and pull all his children out of it. And there he was in his 50s on death's door with hypertension, all these preventable diseases. And so what he kind of developed was this idea of just John Henryism, and he called it a coping style. So he called it John Henry adaptive coping. And it's really this attempt, this high effort attempt to control their environment. So everyone's trying to control their environment through superhuman performance. Like nothing, no matter the pain, no matter the struggle, no matter the adversity, I'm going to keep my head down and keep working, and I will take anything and everything to be successful. And so it's really this really high effort to cope. I see people remember the song. Yeah, there's also like a bunch of comics too about it, but yeah. And so I was just like, that makes complete sense. And I think you really see, especially when I remember when I was working in college counseling and I would talk to kids who came from these kind of families, and I would ask them like, are you taking breaks? Do you know what that, they would have no concept of it. And it's really not uncommon to still see a lot of African Americans. We'll talk about the reasons why. I really have this concept of no matter what, and it's seen as, the tricky part is it's seen as like a matter of pride. No matter what, I'm going to keep going. And so when we think about the role of this, so we have like John Henry Martin, who was the son of slaves, worked his way out of slavery and sharecropping system. We really understand that now. We're really seeing that there is a lot of evidence for intergenerational, transmission of the effects of trauma. So what does it mean to have the effects of slavery kind of going through and learning these ways of maladaptive coping that might keep you alive, right? But what's the cost of these kind of skills and genes that are being inherited as we think about all the pain and the traumatic experiences that families like John Henry Martin's were going through? And so I want us to imagine that, yeah, there's the effect of biology, right? These genes getting passed along and these maladaptive environments. Think about the environments, these sharecropping environments and modern day inner city environments. When we look at things like COVID, we're really seeing like, I saw a study and it was kind of like one of those no-duh studies. It was like, one of the biggest effects of COVID is like living in crowded buildings, like with multiple relatives. I was like, yeah, like that makes perfect sense. Those are those essential workers. Those are those people who can't afford to go out. So are we really having these effects? And that's all driven too. I want us to think about the role that culture is playing in almost learning these behaviors through, especially like parental learning and styles and family styles of this shared coping mechanism. And so we have all these kind of factors pushing forward. And so what I want to talk today about, especially we're going to focus, because my study is really focused on African-American men, I want to really think about putting down the hammer. And this was a portrait of John Henryism. And to me, when I saw this, it was very striking because I think right now we're seeing these pictures. And I mean, like, for me, when I was in graduate school and I remember the death of Mike Brown and the death of Trayvon, and I still remember like the bodies in the street. And I kind of want to think about that notion about the effects of this trauma and this work ethic and these kind of cultural experiences are having on the mental health of individuals. So this is very wordy, but again, I will give out all the slides to this. So I'm just going to kind of hit the main points. But like, what are we seeing about African-American men? We're really seeing that they are probably at the bottom of most health and wellness categories. So they typically have the shortest lifespans of all racial and ethnic groups in the United States. They die at twice the rate of white men do in middle age. I mean, I always think about all the Black celebrities that I kind of grew up with that just kind of dropped dead in their 50s, like Bernie Mac and who's the other one? Bing Rames. You know what I mean? It's just like, it's like a common thing for Black men to die in their 50s. It's like not something that is almost seen as surprising. And that to me should be surprising. And we're seeing these rates are almost double those of all Black women. Now, this presentation will have a lot of parallels between Black men and Black women, but it's also really important to know that Black women have some more protective factors. And we'll talk about those too when it comes to relationships. So we also know that there's these huge kind of sociological effects at the society level. And those are like African-American men are six times more likely than European-American men to be incarcerated. We can think of the effects that being incarcerated has on the mental health of people. And then we know things like protective factors like education are really low, and African-American men are still one of the lowest enrolling in colleges in the United States. So this is Dr. Joseph White. He is basically, he used to call himself the godfather of Black psychology. And he passed away, unfortunately, in 2017. But he really is like the founder of a lot of Black psychology. He is personally, responsible for hundreds, like I would say 50% of the Black psychologists today would consider him like a mentor, and have helped him get into grad school, myself included. But he had this funny anecdote where he said, researchers would come to him all the time and ask him, why are Black men, dying early? Why are they having all these bad health outcomes? And we need the data on this. And he was just like, we're stressed. And he said that like we're stressed, and we all know we're stressed, and we all feel we're stressed, but there's no data because Black men are the least likely to participate in research. That's why they're often called the hard to reach population. And the thing is, it's, that can be kind of dismissive, the hard to reach population, right? It's not that they're hard to reach, it's that I think there has been a lack of interest and lack of awareness of Black men's health needs. And hopefully studies like mine will kind of increase that and help us think a little bit more about that. So again, very wordy, but I'll just hit the main points. So again, when it comes to mental health services, Black Americans are among the lowest served by these. There's less mental health centers, there's way less psychiatry in majority African neighborhoods. And the thing is, they're more likely to experience mental health. We know things like living in urban environments are already risk factors for mental health outcomes. So when we combine all these factors, we're really seeing that they are much more likely to and less likely to get a diagnosis. And when they do get a diagnosis, it's less precise. There's been really strong studies that show that African Americans with things like schizophrenia and ADHD are really overdiagnosed for things that are maybe behavioral. And again, when African Americans do experience these, we're seeing that they experience them worse. They have reduced functioning and more significant disabilities. So they're sicker longer and they're worse when they do get these mental health diseases. And we'll talk today a lot about depression, so that's why I wanted to focus on, because we know 1 in 5 people will have a depressive episode sometime in their life. And so what we're finding is it is really difficult for them to get help. So when they are getting help, it's mostly from a PCP. And we're really seeing too that the environment you get help really makes a huge difference on whether you're going to comply with the help. In general, they're finding that the more medical, the more sterilized the place is, the less likely an African American men, and most men in general, are for actually staying in that environment and finding that helpful and learning to engage in that kind of service. But the interesting part that I always find really interesting is that the attitudes towards mental health are the exact opposite, right? We just talked about all these things, but when we talk to African Americans, researchers consistently find that they have positive attitudes and belief. If you ask them like, hey, you think going and seeing a psychologist is a good idea? They'll be like, yeah, absolutely. I absolutely think it's a great idea. But when it's like, do you want to go see a psychologist? They're like, no, I don't need that. Like, I'm not that crazy. I'm not that bad. So we're really seeing that, that there's this lack of willingness to seek these services. And there's a lot of reasons for that. So one of them is they're less likely to think their problem is worse, right? So we talked about that John Henryism and the fact that they can actively cope and really kind of power through this. So what they're thinking is like, I can power through this. And I often have this story I tell clients when I kind of see them kind of doing this active coping where nothing can stop me. And I'm like, Imagine you had 3,000 pounds on your back and you had to walk up a hill. Just because you can do it, does that mean you should do it? And like sometimes that makes people pause and think like, yeah, and I'm like, you seem like you're carrying a lot of weight on you, right? And that is a one way, like, and we'll talk about more techniques, but that's one way I've often used to kind of describe how active coping and how these kind of strategies can really kind of prevent people from entering services. And so, like, again, we talked about, again, this positive attitude. We think it's great. Yeah, everybody should go, but I'm not going because I can handle it. And so a big question that comes up, and probably something somebody's going to ask, is does this mean that we need to have more African-American providers, right? Let's just hire more people. That'll solve it. But the thing is that there's not a lot. Again, there's 2% of psychologists and psychiatrists are African-American, and there's 4% of social workers. So we know, like, just numbers wise, that's not going to work. So we're going to talk today really about how do we do that when maybe we can't just hire every good Black therapist, because we have to figure out ways to connect and how other therapists, because the thing is, research has kind of consistently shown when they ask the race ethnicity match is, does the person get better? And the answer is no. So the fact is, treatment is effective regardless of whether it's a race match. But what are you getting when the therapist matches your race? You're kind of getting that familiarity. You're kind of getting that I can already talk about cultural things with this person. And instead, right, what we need to think about is how do non-people of color kind of broach those subjects and make that comfortable so that person will kind of engage. And what we're seeing with the utilization of services is that it is abysmal. It is less than 10%. Excuse me. So for African-American men in particular, we are seeing that only 7.5% when faced with any kind of emotional, nervous problem, mental health issue, drug or substance abuse, will seek treatment. They're just not going to go. You know, it's really, really, really rare for that to happen. But there are ways to really increase utilization, and we'll talk about some of those in a minute. So what we do know is that is really helpful is informal support. So really what we're kind of discovering is back, I would say maybe 20 years ago, the thought was, oh, these men must be just using informal support. But what we're finding is that the men who do seek treatment are using a mixture of both, right? So they're using both informal and formal sources. And we'll talk about how that's usually because it supplements each other, right? If you have informal supports, they're saying like, hey, I don't think you're doing that great. I think you should go see somebody. You're much more likely to go see somebody. And so again, most men were either likely to not go at all or seek a mixture. Very few men would just seek professional only. That's a very low number. And so what we're seeing is the consequences of this mental health kind of crisis, especially in the African-American community, is we know when mental health disorders go untreated, right, that it causes a lot of things: substance abuse, incarceration, homelessness, homicide, suicide, right? And you're creating this, what we call, you know, pathway of generational trauma, where over and over again, we're seeing these outcomes. And, you know, this is just one of the reasons why, you know, when people think about, you know, meritocracy and why it's so hard to kind of pull yourself up by your bootstraps is it's really hard when you have like a ton of this societal pressure kind of pushing down against some of those opportunities. And so what I kind of wanted to pinpoint on was, all right, so we know like when most people aren't feeling good, especially when they're really depressed or facing a lot of psychological distress, they kind of seek help. And so I want to know, especially, why did African-American men with depression, you know, why aren't they going to seek help? So that's the kind of the pinpoint question I wanted to look at was, and we'll talk about this later, but it's called entering the sick role. So why do men want to enter that sick role and say, yeah, I think there's something wrong with me. I think I should go get help for this. And that's this like kind of the precise question we're looking at. Because to me, it makes no sense that we've talked about all these huge societal pressures, yet African men have some of the lowest depression rates, right? According to the APA, or at least, excuse me, in the last DSM. So Gary in 1985 kind of set up this model where he was like, you know what, I just don't think African-American men are experiencing depression in the same way, right? And so maybe that's one thought, that maybe African-Americans are experiencing it in a completely kind of unique way. And he kind of was really kind of narrowed down on some factors, and we'll talk about these because my study actually lined up really well, was age, income, household side, employment status, and relationship conflict were really what was closely related to depression, and maybe not some of the other more other diagnostic criteria, excuse me. And so what we're seeing is that when we're just look at symptoms, right, and we look at like men who have not been to work for disability, we're really seeing that it's much more African-American men are really, again, we talk about that, they're having much more severe depression. And again, we're seeing like, why is the overall prevalence rate so low, right? And to me, it's like, is it a criteria? And so my idea was maybe there's a positive coping mechanism. Maybe there is. Let's take a step back and say maybe John Henryism is helpful. Maybe that is protected. Maybe that's what's going on. And so I wanted to look at like help seeking, and if men who are actively coping kind of would seek help. Because what we're seeing again with Black men's help seeking is that most men don't make it past 4 sessions, even when they're really sick, right? And what we're seeing again for depression, 8 to 10 sessions is kind of what you need to even start to begin to kind of manage depression better. And if people aren't going for even 4 sessions, they're not really getting anything. So I wanted to really explore the relationship between depressive symptoms, mental health systems. Masculine self-reliance was something I also looked at, because my original thought was maybe these men are just over-reliant on themselves. Maybe they're not seeking help at all. So that was also a factor that was in there. And so what I kind of used, and we'll look briefly at the model, was the network episode model. And so it really talks more about the illness career. So it talks more holistically. And I'll talk about like even when people who do research, and these are models that will better fit African-American audiences than traditional kind of help-seeking models. And so again, the 5 things I looked at were depression, masculine self-reliance, John Henryism, attitudes towards professional psychological help, and then general help-seeking. And so I wanted to look at like, what are their beliefs? So again, we talked about them normally having positive attitudes, so I wanted to verify that. And then I wanted to look at help-seeking. So general help-seeking looked at all sources of help. So on there was spouse or partner, best friend, and it listed other, priest was on there, pastor. So we want to look at, because traditionally it's kind of thought that African-American men might seek help in the church, because the church is, still the cornerstone of the Black community, and perhaps they were going to help from the religious community. So I wanted to explore where they're actually going for help. So that's a really interesting measure that kind of helps you look at where people are actually going to seek help from. And the network episode model, and it's easier if you see it visually, it really just looks at how social factors, right, like gender, age, education, work status, really impact the social system support and the disability of a person. So it talks a lot about what are we looking at and where are we looking at, and it's dynamic rather than a static model, because again, I think often when African Americans are studied, we use some of these more static models that really miss out on a lot of the societal pressures that might be going on. And so I really like this model because it included both coping style, which I was looking for with John Henryism. It looked at a bunch of the demographic factors, and it also included, income, education. So there was a lot of things to kind of look at. And the thing I was really focusing on, though, was just that one factor in the illness career, which is how do African Americans decide that I'm sick and I need to seek help? So what happened was, and this might be because this was a very convenient sample, and so one of the things I think that happened was I placed this where, really, I think tech-savvy people kind of would stumble upon it. And a lot of the groups I used also were Black professional groups rather than maybe university populations. And so what I really found was I got a really excellent group for asking this question. So I got men who were mean age 32, average income 60,000, mostly heterosexual, mostly employed, excuse me, typo, and mostly college educated. And the thing that really was the kicker was that they were mostly depressed. The average on my depression measure, 20 was the cutoff for moderate depression, and the average person in my study was 22. So these men were depressed, and the thing was also that they were all active copers. These were mostly men who had that idea that when things get bad, I need to buckle down and really power through things. And so what I found was that having that coping style, those men that really had to power through everything, it was actually negatively correlated with depression, right? So it really actually seemed to be protective, right? Again, further studies are necessary, but when men were actively coping, they were actually, feeling less worse, and they were more likely to seek help, right? So they were more likely to talk to somebody about it. They were more likely to surround themselves with people. And they had better attitudes towards psychological help. The only problem was they did not, when we looked at who they were seeking help from, it was usually not a mental health professional. Spouse and girlfriend were number one, followed by, close family. So that would be parent, sibling. Priests were like the least likely. And I think that's a shift in like society. I think I would say 20, 30 years ago, it was really seen that the church was like the cornerstone. But I think for Black men, there are other things they're looking for that maybe the church is not offering. Especially when I think about, a quarter of my participants were LGBTQ, identifying individuals. So that kind of makes sense that would be low. So these men were mostly seeking out their partners to kind of give their grievances to when they needed help. And I asked both for general help. So like if you're feeling like depressed, and if you just need help for like or if you were feeling suicidal, that's the other question. And in both cases, they're pretty much going to go to the person they were dating at that time. Or next would be like that close family member. And again, thinking that a lot of these were single people, that'll be really interesting to see. So what can we take away from this? So John Henryism seems to be protective. And so what we looked about were, there was kind of 6 main things that kind of he found to be protective was, of course, SES. And what we found too was the more income people had in our study, the less depressed they were. Again, we found that, those who were married, again, lower depression rates. And the other thing we found was another factor is called the healthy survivor effect was found in this study. And again, that's just the thing where if you have a lot of young people go through a really bad environment, those who survive are going to be healthier. So what we found is for depression research, as African-American men hit middle age, that's when depression is the worst. So up to about age 25, depression rates are kind of stable. And then there's this huge spike in middle age, and then there's another lull in older age. But again, when we talk about that, 6 times higher middle-age death rate, that means there's not a lot of men who are making it through those times, really healthy. So the things to really consider, and I'm going to try to wrap up pretty soon, okay, are the role of social networks. So the more extensive, the healthier, the bigger the informal support network is, the better off the person is. And we'll talk about I'll just talk about it now. The way to really think about this is often with clients, we encourage them to, get a hobby or do things. But with African Americans, this can really be a critical skill. And again, oftentimes, especially with women, it seems the church is a good option. But for African American men, it's going to be really important, especially when working with them in therapy, to really figure out how to connect them with people, whether that's even like going to play basketball at the park, whatever it is, but they need to find a group of people because they need a support system to kind of say, hey, I think something's up. Just anecdotally, I was talking to somebody and they were saying how they went home and all of a sudden their friends were like, hey, I've noticed this pattern in your behavior. You should go talk to somebody. I was like, that was really good advice. And it's like, it seems obvious, but these are the kind of psychosocial factors that really make a difference when treating African Americans. And again, really including family members. How do we think about including family members in treatment? I think oftentimes we'll have clients, we say, well, we're seeing you individually. This problem's individual. And sometimes that means for African American clients, it might really be beneficial to encourage them to involve family. And sometimes that feels uncomfortable. It's like, oh, they don't want them there. They don't want mom there. And really trying to encourage them. Sometimes it requires you finding like an outside therapist or really trying to connect in some way. But the more you can kind of get them engaged and other family members engaged, sometimes that can be a lifeline. Again, after you assess for trauma or dysfunction in the family. But that can really sometimes be something that might not come to the top of the mind, but can be something that's, again, really beneficial. And so, APA is really stressed, really understanding culture, and I'm not sure what that looks like. But so I'll give you an example of what that looks like. One of the ways that looks like is like really thinking about the language we use. So if a client comes in and or a person you're talking to comes in and you say like, oh, you seem really depressed, or you scored really high on our depression measure. Sometimes we assume that people know what like words like that mean. And what research has really shown is for like African Americans, when asked about those, if you ask about those symptoms and ask them to name that, they might say like, oh, that person's, in a funk, or that's just being stressed. I think a lot of African American men just see that pain, that depression, that low mood, that, and so that's just stress. That's just work. That's how you're supposed to feel sometimes. And really going through and being like, this is clinical, sometimes can be really helpful. And then sometimes letting them use their own language. Don't fight. If a client wants to call, African American wants to call how he's feeling stressed, and you see it as, this is really bad, he's really depressed, I'm not going to fight with him over that language, right? And that's just one example of the ways we can really think about connecting on like a more personal level. Because again, we have this huge cultural stigma. The one thing I wish I had included and hope to include in future studies is that there's huge, huge, huge stigma of mental health in African American, in the African American community. I feel like that's the elephant in the room that wasn't mentioned in the study, is that that's the reason. That's the reason why they know it's a good thing, right? And can say, I think it's helpful. It's been beneficial for people that I know who've done it, but I don't want to do it. It's because, what does that mean to be seen as weak? What does that do to, that mask, that shield, that John Henryism, right? It kind of cracks it. So it's better just to keep plowing ahead. Again, we talked about the healthy survivor effect, but really we're seeing that again in this study and in other studies, marital status. So married men are doing better, younger and older. But again, really paying attention because there's a huge increase in depression in adolescents and young adults that I don't want to I'll be remiss to talk about. The suicide rate has really skyrocketed in the last 10 years. And I think if we think about some of the societal pressure, we can see a lot of that makes sense as well. And really, how do we kind of meet the needs of it? Sometimes it feels like there's a lot of fires in Black mental health, but we're going to keep plowing ahead and trying to, make a difference. And again, really, socioeconomic status is huge. So the ability to have health insurance, because if you don't have health insurance, you're not going to you're not even going to think about mental health. That's the least of your concern. You haven't seen a doctor in years. And so thinking about other community initiatives, again, for some organizations at the community level, this looks like, enrolling clients in insurance, making sure they get on Medicaid and Medicare. At a larger level, it might mean just advocating for that, advocating for more mental health parity, for more funding, whatever that looks like, but really understanding that that plays a huge effect on whether or not men seek services. And so, end of the day, is John Henryism an asset or a liability? And I think, my personal opinion, I have not done the research yet, is it's both. I think John Henryism is really good in the short term, get through a short-term crisis, put your head down and kind of power through it. Sure, that works. Sometimes you need to do that. Sometimes we all need to, power through a short-term crisis and know things to be better on the other side. But I think if you use that kind of approach for years, if that's your only tool, I love how this like just a hammer. If that's your only tool, like that's going to cause problems because sometimes I've used this analogy too. Sometimes you need the right tool for the right job. You need pliers, and if you only have a hammer, right? What does that do to relationships? And I think we're seeing that relationships are often the biggest concern for African American men. And one of the best ways to get them into treatment is, yeah, let's improve your relationship because you've been kind of holding this all in and now you're with another person. How does that kind of look? So, of course, the number one way to kind of support Black male clients or Black males with their mental health is having Black clinicians on staff. And while that's great, because having a Black face, having somebody say, hey, I want a Black clinician, having a Black clinician come and say like, hey, I know you want a Black clinician, but we have excellent staff here, and let me explain to you that X, Y, and Z. That's a friendly face. Sometimes that's enough to get people into treatment, and we don't need to think about like, oh, we got to hire 1 million Black therapists because again, this numbers game, it's not going to happen. But so how do we be more effective? And so we have to think about setting, right? If we want to bring in more clients, we have to think about what does the environment kind of look like. And so this is really difficult, especially in New York City. But at other agencies, I remember I worked, and I'll talk a little bit about at the end, is, if you have, let's say, pictures of Black faces and families that are Black up on your wall, right? That says to somebody who's maybe coming in that this is a safe place. I already touched on involving key family members. If we're always talking about mom, maybe we bring mom in for one session, right? It's not, maybe we don't do couples, but maybe I, facilitate discussion between them. Utilizing groups is a big deal, and I want to, throw in a shameless plug for I really want to start an African American men's group. I think that there is a level of skills that's definitely needed from African American men's, emotional regulation, anger management, right? Talk about substance, talk about relationships that's not really going on and can really make a huge difference. And one thing you can really do is openly discuss race, racism, and discrimination, right? So how do we have it, how do we talk about it that first? How do we talk about it in the intake? Hey, you're a Black male, I'm a white woman. How is it going to be to have therapy with us, right? That can be jarring, right? But like at the same time, that can be like, whoa, this person's willing to talk about it, right? And acknowledging that and talking about that, right? So this person knows that I can talk to you about these maybe culturally sensitive issues. And if you don't understand, you're going to try to understand. And so one example of an agency, I'll just talk about it briefly, that really I think is like probably the top African American community mental health center is Minority Behavioral Health Group in Akron, Ohio. And they use everything as African-centered and African-American centered approach. And so like I would say their staff is 95% African-American men. And it's by design to kind of address the needs from, again, one of the most economically depressed areas in Ohio. And so it utilizes this optimal theory, which is really a cognitive-based approach. And it's called belief system analysis because it challenges clients to really see the world from another perspective. And their perspective is they chose the African perspective. So talking about restoring some of that historical trauma and addressing some of those past issues is really huge. So some of the factors that are talked about are like spiritualism, interpersonal relationship, holistic worldview, diurnal logic. And that's just kind of, diurnal logic is the same thing as both and, right? So things can be Black and white, right? They don't have to be one or the other. And so this is like a way to put a African-American approach to like CBT, right? And the response rate has been incredible, right? So we see clients who will have been there for 30 sessions, who've really processed trauma, who are bringing in families. And the way they do that is really by a team approach, right? So they have case management, psychiatry, and everybody kind of works around that. And the staff kind of are constantly educated about these kind of factors. And so we're seeing that when things are done in a different way. I just say this to say, not like every agency should be this agency. I don't think that's applicable. I think it's a good fit for its community, right? And so like thinking about what is a good fit for our community, how can we adjust if we really do want to address or bring in this type of client, how do we do that? How do we kind of think about our setting? How do we think about our language? How do we think about the way things are organized? The art we have on our wall? You know, who we have at our front desk? Like, what does that say about us? All right, I think I did it. That was 45 minutes, a little bit over. What I got there.
All right. Awesome job. Yeah. So thank you, Dr. Osei. So that was I think, really kind of thought-provoking discussion. One of the things that I was thinking about as you were talking about John Henryism was this idea that that seems to be correlated with, medical health issues. And yet those individuals seem to be doing, better in terms of seeking out mental health treatment. I was wondering in your study if you looked at all at the medical health of the individuals.
No, and my guess is their medical health is worse, right? I don't think that's healthy. And so like my ideal study would be to do like if I could get, partner, any doctors out there know somebody who would partner and get like blood pressure readings while we're doing this, right? And to get screenings, I think we'd really see a really important effect. I would guess it's negative. I don't think this is a healthy way to manage your problem.
Yeah, no, it's interesting because I think as psychiatrists, we often, like, the patients that we're seeing don't have primary care doctors, and they kind of think of us as that way, and we may be the one kind of person that they trust to actually like seek out medical care. And I think you were saying in particular, Black men are kind of weary of that sterilized medical environment. So it seems to me that therapists and psychiatrists would have like a real opportunity here for the men that are coming in to look at their medical health as well, their physical health. I'm wondering what you think about that.
Huge, yeah. I'm a huge fan of that. I think a lot of the programs that do a really good job of that have a multidisciplinary approach. So like just before I left, Minority Behavioral Health Group partnered with the local hospital to make sure that medical care was addressed. Because a lot of the times there can be an underlying, a lot of times there is, right? Because we know, especially in like economically depressed areas or people who don't have a lot of resources, they're gonna have some health problems. It's pretty reliable that those things are connected, especially thinking about the age and the factors and the fact that a lot of Black men are not going to see, like you just mentioned, they're not seeing PCP.
Right.
10 years without seeing a PCP, something probably needs to be checked.
Yeah, no, I think there's research, and men in general are kind of worse at those things. And so, yeah, it's definitely both. Along those lines, how much did you kind of compare the Black men to, say, Black women or any other kind of minority, people of color in seeking treatment?
So there is like almost, it's not a parallel study, but I had another study that was very similar to mine. And as I was doing it, I was like, oh, this is really interesting. It's actually done by one of my advisors. And she looked at John Henryism and she utilized the strong Black woman kind of stereotype. And there's a measure for that. And it's also a very similar idea that Black women are invincible and can carry all and can do everything. And she found a very similar effect that women also, when they were using this strategy, that it was effective. And that's why I think it's such I'm not addicting, but it can become a very overused strategy in coping because it is easy to use and it is very effective. And so she found that with women, it was also a highly effective strategy towards managing mental health concerns.
Yeah, it seems like there'd be a lot of outside reinforcement for this strategy. People would be praising the individual for using it, even though, underneath that may be, like you said, that's the only hammer they have.
Right.
Yeah, very interesting. Also, what stuck out was that comment you made a little bit towards the beginning about the ethnicity match and it not actually mattering in terms of the therapy outcome. Because I think, as somebody who looks at people trying to come into our practice and screening and matchmaking, we're always trying to make the best fit, and sometimes that's a factor. People are very direct about that, and then at the end, you're talking about how it's important to have Black staff and things. So how do you kind of like reconcile that finding, or what do you make of that finding? Just anything you could say about it, because it surprised me.
Yeah, and so the thing though says if all things being equal though. So if you have two good therapists or two very skilled therapists, yeah. But what we also see that I think is even more beneficial is that the more multicultural training that a therapist has, the more that they've done the work and thought about these ideas and thought about these approaches, the more likely they are to retain those clients. That would only make sense, right? And so we have to think of it as a both. So having a face opens the door, and I like that expression. Just because you crack the door open, you still have to walk through it. So having, I think, black face opens the door, but it doesn't invite people in. I think what will invite people in is, again, being able to kind of show them. Because the thing is, if we're saying that we have 2 to 4 sessions to get this person, that means you have 2 to 4 sessions to really develop a relationship. And those 2 to 4 sessions, I think, are critical in building rapport and getting that person to stay in treatment. So really thinking like, I think there needs to be more thought when you have that African-American man in front of you, you have to put a little bit more thought into thinking like, let me make this connection, let me be willing to be vulnerable and talk about these issues to kind of do that.
Yeah, I think oftentimes in supervision, supervisors will say to a new trainee, like the goal of your first session is just to have a second session. And it seems like that's really important here in terms of getting that ongoing engagement and getting past that. The goal of the 4th session is to have a 5th and so on and so forth. So you also did, mention in kind of staffing clinics, you mentioned, clinicians, but then the percentage of Black clinicians out there being statistically very small, having, Black front desk staff and things like that. And, just to be kind of frankly about it, like, do you think there are issues if, say, there are multiple Black front desk staff and then fewer Black clinicians, and does that send a message that's problematic? Or what do you think about that?
I think you got to take it situation by situation, but I think sometimes that's the nature of it, right? It is difficult to hire, Black professionals. We are few and far between. And I think if the effort is made, there's always going to be an imbalance. And we talked about this a little bit when it comes to SES. There's just more individuals who are going to be available for those positions. And I think it really comes down to how those individuals are treated, right? How they're incorporated, their purpose in the organization. Like, again, one of the things that I keep talking about them because I really love their model was one of the things they did was that whenever we had any trainings, whenever we had any meetings, it was a very communal agency, right? One of their principles was African communalism. So everything was communal, right? There were still people in charge, and they even used an African model for that, calling them like almost elders, but everybody felt like I did not feel like it was a very egalitarian model. So even thinking about what are ways we can, make it more egalitarian, where when that person walks in, here's the thing, to me, it's when that person walks in your door that they can't tell the difference between how the front desk staff are treated and how the therapists are treated. They see everybody the same in the agency. And unless you tell them, like, I'm Dr. So-and-so, they wouldn't know because they just see everybody is there and happy and being treated equally. That's a huge statement.
I see. Yeah, that's interesting. In the groups that we run a lot of mentalization groups, and we have co-leaders. We have had multiple instances where a group member just thinks that one of the group leaders is another group member. So I think we are trying to kind of give that spirit, and even I think part of the spirit of doing these grand street rounds, right, was to take that sort of precious academic thing and allow more people to see it. So that does make a lot of sense. Could you talk a little bit about your experience in training in grad school? And, I know you mentioned your dad is a mental health professional and leader. And if you feel comfortable, how were your experiences as a Black man in training? I imagine there weren't as many of you as we would like.
So, like, here's the trick, and I mean, I really want to give him credit. That's why I throw him in any presentation I can, is that, like, Dr. White really taught me, like, the power of, like, small, like, mentoring and, like, small changes. So, like, this is why I'm really big about, like, finding gatekeepers. And one of my professors in undergrad, who wasn't a Black man, who was a white woman, was the person who's like, this is a gatekeeper. We'll, like, email this man. And I was like, okay. And, like, literally, that's all it took. It was literally for me, I've always been like, I want to go where I feel like I can be mentored. And so like, again, I went to UPenn and I wanted to work under Howard Stevenson, who's a Black
Mhm.
psychologist. So I've been very like blessed and lucky in that way to kind of, I seek that out. And that's why like people are like, why'd you go up to school in the middle of Ohio? It's because like I wanted to find people who did this kind of research, but also who saw clients, right? It's not a
Mhm.
lot of people who both do research on Black health and are active therapists. And so like I wanted to do both. And
Yeah.
so I've been lucky in that way. And if you're interested in those subjects, I know like people are that it's totally possible to find these really interesting programs that do this kind of thing.
Mhm. Yeah, so I think moving forward in your professional career, kind of how do you think of yourself, 5 years from now, 10 years from now, in terms of what, if you're in a good spot, what would that kind of look like for you?
Probably more of the same, actually. Just bigger things. But I still want to be a clinician. I still want to. I always feel like I have to always see clients,
Mhm.
and I really want to like again expand coaching, consulting opportunities. I really want to teach organizations and groups of people how to do this, how to be more multicultural, how to deal better with difference. So that's really where my passion is, also.
Yes, and I know you've started doing some of that with us, and have done that beforehand in terms of talking businesses. And I think along those lines, there's like a lot out there. There's like an explosion of resources for companies to get diversity training or come to this or that, and learn how to be more culturally sensitive. Probably a lot of that is not really helpful. I know some of the research has shown that really, it's a nice afternoon, but it doesn't actually change behavior. The few minutes that we have left, any kind of suggestions of what people should look for in a consulting program, a training program, of things that could, actually make a real difference?
Yeah, find something as interactive as possible. That's my thing.
Hmm.
If it's kind of like going to be a presentation, right? Like see the presenter, make sure it's something engaging. If it's just something kind of copy paste or some sort of PowerPoint, people are less likely to remember that. But the ones I've had, and I don't know, I don't want to tie myself down or anything, but the best trainings I've had have been ones where I've had to get up, when I've had to interact with somebody, when I've had to go say hi to that coworker I've known for a year and just have been like ignoring. Those are the best kind of trainings. And I think if you can find something like that, something really active or really dynamic presenter. And again, sometimes I think people look for the big speakers. They look for, the big corporate company that comes in and the slick PowerPoint. Sometimes the more powerful one, and I really suggest, is find a local advocate who speaks, right? And
Hmm.
have them teach a very specific subject about maybe if you want to have, your employees learn more about African Americans, right? Bring in a local African American advocate who is a speaker, right? Meet with them beforehand, talk to them, talk about some of the things. Because I think what I want to stress is, I think what we need now is less trainings, less readings, and we need more experiences. Like
Hmm.
my thing is like, and this little anecdote, I'm gonna call myself out. I was with my partner, and they're like, "Well, you listen to only men. Like all your music is men." And I was like, "No." I was like, "No, no, no."
All
I was like,
men.
"All men." And I
All
was like,
dudes.
so for July, I was just like, I'm only going to listen to women. And this is an extreme
I love it.
example, but like it was a way for me to say like I'm going to check myself. So for me, it's like read books on like from Black authors, read Ta-Nehisi Coates, go to places of Black people, right? Like it's about learning. The more we learn about the cultural experience, like if you didn't know this about Black people before, that they we tirelessly cope with problems, that's a part of the Black experience that you're not going to see. So when somebody comes in exhausted and you're just like, oh, depression, we're going to do this it's going
Yep.
to feel dismissive, right?
Yeah. So
Right?
and I think I have to say, I know we have to wrap up, but I did not know what that term meant beforehand. So, and I think I imagine many of our audience didn't as well. And this has been just a great talk, and thanks so much for being our first person for Grand Street Rounds. And for those that were tuning in, we'll be having these periodically. We'll put out on our social media and newsletter. And this will be send a newsletter out with like resources, and hopefully technology willing, also put this on YouTube very soon. So thanks so much, everybody. All right. Bye-bye.